Hi, my name is Dr. Mandar Nadkarni. I am the head of breast oncology at the Kokilaben Dhirubhai Ambani Hospital, and I am the primary oncoplastic breast surgeon in that hospital for the last 16 years now. Uh, I am very thankful to the organizers of this event that I was invited here. This conclave was really great. A lot of new things that I have learned here, especially the monitoring of patients, and that is contactless monitoring, and that was really great. Honestly, I was not really aware of all these things, probably because of my specialty, which is surgical oncology. But I was thoroughly impressed by what was discussed here, and I seriously feel that at some point in time it has to become part of practice, in even in my specialty. And I'm sure my hospital will be looking in that same direction, when it comes to adopting these kinds of newer technologies. So when you really talk of newer technologies, artificial intelligence has not really made a big dent in my specialty, and my specialty is breast cancer. But I can talk a little bit about what technology has done, in our field. So if you really look at it, once upon a time we would do a surgery for a breast cancer and then take out the tumor, and you take out the nodes from the armpit, which is the standard care, and you send it for a histopathology, and then you get a report. And basis that report, for years and years and years, we made a sort of a guesstimate of what is the chance that this disease is going to recur in the patient's body, and basis that, does this patient require chemotherapy, something more, radiation, tablets, or whatever? The main crux being whether this patient requires chemotherapy, because most of the unpleasant side effects in our treatment happen with chemotherapy. Mind you, chemotherapy in patients who need to take it is life saving. So, let me make it very clear that if those patients who need it, they have to take it. But if you can avoid it in those patients who really don't need it, we should try and avoid it. So for a long time, we used this histopathology report, and we used to make our decisions basis that, because that's the way it works. Then came the genetic technology, and today we have genomic assays, and these genomic assays look into the cell, and they tell us what is the risk of recurrence. So they give us recurrence scores. There are different ones available, and I'm not going to talk about all of them, but I just want to say that technology, like this conclave said, every single year we are going to have more and more technology, and we have to see how we can fruitfully adopt it in our practice to make uh, patient care better and better and better, and getting better and better cures. So coming back to breast cancer, we have these genomic assays, and this genomic assay that we do on this certain group of patients with breast cancer, the hormone receptor positive ones, actually helps us avoid chemotherapy in 85% of patients. That's a huge big number. That's a big deal. Previously, if we were treating 100 patients with chemo, today we are treating only 15. 85 don't take chemo, and they get the same cure rates. So technology is there. We have to understand, as clinicians, as people with a certain bit of good common sense and knowledge, whether this should be adopted or whether this can be discarded. And if we feel it needs to be adopted, then we should be doing relevant studies to be sure that it really impacts healthcare. And if it impacts healthcare, we have to bring it in, irrespective of how difficult it is to adopt it in our field, because that's eventually going to improve healthcare in general for all our patients.